Hi, I am Abby Phillips, and I'll be going over my fourth video, which is over cardiogenic shock. So, cardiogenic shock is a life-threatening condition in which your heart suddenly can't pump enough blood to meet your body's needs. The condition is most often caused by a severe heart attack, but not everyone who has a heart attack has cardiogenic shock. Cardiogenic shock is rare, it's often deadly if not treated immediately. When treated immediately, about half of the people who develop the condition will survive. So, here are some of the specific signs, symptoms, and physical findings that you would see with your patient with cardiogenic shock. Rapid breathing, severe shortness of breath, sudden rapid heart rate, loss of consciousness, weak pulse, low blood pressure, hypotension, sweating, pale skin, cold hands or feet, and urinating less than normal or not at all. So, imaging for suspected cardiogenic shock, um, echocardiography, or ECG should be performed early to establish the cause of cardiogenic shock. It provides information on global and regional systolic function and on diastolic dysfunction. Chest radiograph findings are useful for excluding other causes of shock or chest pain. Most patients with established cardiogenic shock exhibit findings of left ventricle failure, the radiologic features of which can include pulmonary vascular redistribution, interstitial, interstitial pulmonary edema, enlarged Hiller shadows, the presence of B-lines, cardiomegaly, which is your heart's enlarged, and bilateral pleural effusions. Angiography is urgently indicated in patients with myocardial ischemia or an MI who also develop cardiogenic shock. Angiography is required to help assess the anatomy of the arteries in the heart, as well as evaluate the need for urgent revascularization in your patient. So here is an image of one. So you can see this patient with cardiogenic shock disturbance, severe stenosis of the right artery. There's also another image from a patient with cardiogenic shock, which reveals severe stenosis of the right coronary artery. Following angioplasty of the critical stenosis, flow was reestablished in this patient, and the patient recovered from cardiogenic shock. So, hemodynamics for your patient in shock, pulmonary artery pressure is typically elevated due to the pulmonary congestion. Your pulmonary capillary wedge pressure is usually elevated. It's greater than 10 millimeters of mercury due to the left ventricle dysfunction and increased filling pressures. Your cardiac output usually is decreased. Your systemic vascular resistance usually is increased as the body tries to compensate for the low cardiac output by vasoconstriction. Your mixed venous oxygen saturation is low, indicates inadequate oxygen delivery. Your stroke volume is typically decreased, and an ECG should be used to diagnose an MI. Common medications that we use for patients in cardiogenic shock, patients with an MI or acute or ACS are given aspirin and heparin. Clot busting drugs such as tissue or TPA to dissolve artery clots, anti-clotting medicines such as aspirin or heparin to prevent new clots, drugs to increase the heart pumping ability such as dopamine or norepinephrine, nitroglycerin to relax and widen blood vessels. Sorry, I'm having a trouble pronouncing things today. So, and typical ABG for cardiogenic shock. Early stage, your patient can have respiratory alkalosis, where their pH is high, PaCO2 is low, their bicarb can typically be normal. And then in the late stage, pH is low, PaCO2 is very high, their PaO2 is low, and their bicarb is also low as well. Mechanical ventilation for cardiogenic shock. Just like the other shocks that I went to, they really like to keep with the low tidal volumes and low PEEP as well. So lung protective ventilation. So low tidal volume is typically what is used for cardiogenic shock. The moderate PEEP is wanted to maintain alveolar recruitment. So typically they want it at 5 unless the patient has major oxygenation issues. So close monitoring of the plateau pressure to avoid excessive lung injury. You want to keep it below 30 centimeters of water. Always titrate the FiO2 to maintain adequate oxygen saturation levels while minimizing oxygen toxicity. Your respiratory rate, as well as the other shocks that I've gone through, are set to maintain desired PaCO2 levels. So specific concerns in positive pressure ventilation. Concerns, brain damage can lead to cognitive impairment. Heart damage can include heart muscles that can rupture or damage to the muscles or tendons that support the heart valves. It can also give liver damage, kidney damage, which can lead to acute kidney injury, which can require renal replacement therapy. It can also cause stroke, cardiac arrest, pericardial tamponade, which is pressure on the heart due to fluid buildup. For positive pressure ventilation for cardiogenic shock, positive pressure ventilation is often used in patients with cardiogenic shock to improve gas exchange and potentially stabilize their hemodynamics by reducing left ventricle preload and afterload, thereby improving cardiac output and tissue perfusion. However, careful monitoring is crucial as positive pressure ventilation can have detrimental effects depending on the underlying cause of shock, particularly if right ventricle dysfunction is prominent in your patient. So summary, we went over physical exam findings, imaging, just like the others, ultrasound, CT scans, chest x-rays are popular in angiography, hemodynamics and monitoring, medications, ABGs, vent settings, and specific concerns that can happen, cardiogenic shock and positive pressure ventilation. So cardiogenic shock is a medical emergency that occurs when the heart can't pump enough blood to meet the body's needs, depriving it of oxygen. It is often triggered by severe heart attack, but it can also be caused by viral infections, abnormal heart rhythms, blood clots, or worsening heart failure. All right, and let's end.